Hi guys. I know after that session for sure you you share, my first reaction when I joined the review for the first time. And this is it. How do I not know this? And if this is your
because
reaction,
because some people are watching the false prophets of the NGN on the internet that are teaching obsolete concepts or that are
that's
teaching NLE concepts or have yet to pass the NGN and they're teaching. Okay?
that's true, sir. So that's the reason why we know that you are, you're here at the right place. And I hope that, as you're learning, you're also enjoying, the different updates that you're having. And this is all for free. So let me get down to my questions. So these are mostly diagnostic tests. So let's see your knowledge about this. So this is the first question. A nurse is reviewing the ECG of a client who presented with muscle weakness and
I
palpitation.
protest, Ma'am Che. You should have your picture there over mine. Okay.
Okay, sir. The ECG tracing shows tall peak T waves and widened QRS complexes. Which of the following medication should the nurse anticipate administering? Select all that apply. Now, when you're looking into questions such as ECG, most of us are expecting to see the strip. And to be honest with you, sometimes your NGN will include the strip, but sometimes they will just describe what is being seen in the strip. So you should have the knowledge of knowing what to see in the strip and also what how it is being described. So based on this, so let's see, guys. Let me use my pen for this part of it. So it says here your manifestation of your client muscle weakness, palpitations. Now there are many conditions that can have muscle weakness and palpitation. But when you look at the ECG tracing, it says there tall, picked T waves with widened QRS complexes. So guys, before we answer the question, can you tell me what condition does this ECG tracing um, alludes to? Anybody? I think some of you know tall peak T waves, very good, is
Let me read
hyperkalemia.
to you, Ma'am Che. Some of them are saying hypokalemia. Some of them are saying
Oh,
hyperkalemia.
so the answer should be hyperkalemia because in
Maybe they
hypo,
get confused with muscle weakness because it's present in both hypo and hyper. Yeah.
yes, that's why your difference, guys, is that in hypokalemia, usually a prominent U wave or the presence of U wave that is usually larger than your T wave. So if that is the case, presence of U wave plus, you may or may not have this, but T wave inversion signifies hypokalemia. But if they mention tall peaked T waves, that is your hyperkalemia. Is that clear, guys? Okay? So once you have that, so we know now that this is hyperkalemia. Which of the following medication should the nurse anticipate administering? Okay. So you have here several medication. Please tell me, should I give calcium gluconate? Yes or no? On the chat box, please. Calcium gluconate. Very good. The correct answer is yes. Why? Why should I give calcium gluconate to a patient with hyperkalemia? You know that one of the things that your potassium damages is your heart. And your calcium gluconate will serve as an emergency treatment to prevent the potassium from destroying the heart. So this is now a yes. So this is your first line emergency measure. Emergency drug. What about kayexalate or sodium polystyrene sulfonate? Kayexalate. You know that this is a potassium binder, so it is a yes. Okay. Now, kayexalate binds with potassium and removes it out of the system in a slower pace than calcium gluconate protecting the heart. So that's the reason why we give this IV for because it's kind of faster as a cardiac defender. Okay, and then you have their kayexalate. Now, what about number three? Regular insulin with dextrose. So you know your sodium potassium channels, so it's a yes. Now the idea here is your pathophysiology that when insulin is there, insulin helps the potassium to enter the cells, right? And because you're using insulin, sugar also enters the cells. So to prevent you from having hypoglycemia, we give it with dextrose. Okay? So yes. What about number four? Spironolactone. What do you know of spironolactone? What is its drug classification? It is a potassium-sparing diuretic. Should we spare potassium if we have a lot of it already? What do you think, guys? Potassium-sparing diuretic? It's a no. So number four, no. What about number five? Furosemide Lasix. Guys, you know that when you urinate, potassium is excreted out, right? So giving your loop diuretic will enhance excretion of your potassium through the urine. Therefore, 5 is a yes. And number 6, sodium bicarbonate. What do you think about this? Ooh, I love it. What do you think, guys? With sodium bicarbonate, is it a yes or a no? Now, usually, guys, yeah, it's a yes. It will be helpful, most especially if you have a client who has metabolic acidosis together with their hyperkalemia. So, for acidotic clients, we also give your sodium bicarbonate. Now, what do you think, guys? Is this helpful? So, if you are not able to get in to understand the diagnosis that this ECG strip is hyperkalemia, then how will you be able to include the correct medications? So it's important for you to first look at the symptoms, look at the description of your ECG, determine what it is, and then eventually know which drugs are needed. Okay? So, yay! Good job to those who answered correctly. Let me go to the next one. For the next diagnostic test, I think this is maternity. There we go. A nurse is reviewing the fetal heart monitor tracing of a client in active labor. The strip shows abrupt drops in fetal heart rate unrelated to contraction. Ooh. What kind? So you see the word here, drops. So it's a kind of deceleration. Right? There you go, right, Camille? Now the question is, but it says here the fetal rate drops are unrelated to contraction. So they didn't say it happens early in the contraction. They didn't mention it happens late in the contraction. They mentioned it's unrelated to contractions. What type of deceleration are this? What type of deceleration is this, guys? Your answer will be variable. Very good. And if you recall, guys, listen, if you recall our different deceleration and your fetal heart rate as compared as it relates to contraction, remember your mnemonic veal chop. Yes, Camille recalls it. So you have variable, right? Deceleration, you have your E, early. Deceleration, you have your A, acceleration, you have your L, late deceleration. So, and you have your chop as the, what it meant. Okay. So, variable deceleration is usually associated with cord compression. Okay. Early deceleration, H, head compression. Acceleration, this is normal, right? So, oxygen adequacy, meaning it's good, it's okay. Some has okay here, so it's also okay. Late deceleration means P, placental insufficiency. So class, the key is that first identify what deceleration or acceleration it is. So as you can see, it's a drop, so it's a deceleration. It's unrelated to contraction, so it's variable. If they mention it happens early in the contraction, then it's head compression. If it happens with acceleration, that usually happens. That's normal. So accelerations are normal. Late deceleration meant that after the peak of contraction, that's the time that the fetal heart rate decreases, which means that there is a deficiency in the blood flow coming to the patient or to the fetus after your contractions. Okay? So that's late deceleration. That's why it's placental insufficiency. Now, with that in mind, look at this keyword, cord compression. Okay. Which then will be the reason for this variable deceleration. Select all that apply. Pile. Select all that apply. With the keyword cord. Give me your numbers, please. It's a SATA question. It's a SATA. Select all that apply. Saan dyan yung may indication that it's cord compression? Cord compression. Ooh. Come on, keep it coming. Cord compression, nandyan na, guys. Baka naman. Okay. One. Some of you says one. Correct. Umbilical cord compression. Andun na, di ba? Okay. Guys, listen. And this is usually what people miss. Why is the cord compressed? What is the reason why it's compressed? So it could probably mean that the cord compression arose from decrease in your amniotic fluid. Guys, usually this is missed. If your amniotic fluid volume is low, okay, what happens? And the child moves about. So there is a tendency that the umbilical cord then will be compressed. Do you get it? And they miss this. Of course, you get nuchal cord. Of course, you get cord prolapse, right? But oligohydramnios, they miss it just because it doesn't say cord. But if you think about it, if my fluids are down, if the amniotic fluids are down, then there's a tendency that when the child changes position, the baby changes position, the cord will be compressed. So your correct answer includes 2. Now, what about 3? Uteroplacental insufficiency. It's there. It's late deceleration, so that's a no. Okay, that's late deceleration. Nuchal cord. There's that cord. So, yes, it should be included. Maternal hypotension. Question. When you say hypotension, what does it involve? Hypotension, does it involve blood supply? So when you say blood supply problems, to what deceleration is it usually associated with? Lack of blood supply, because the mother is hypotensive, so there is lack of blood going to the baby. What is that? Tell me on the chat box, is it variable? Early, late? Yes, it's late deceleration. Though they didn't mention uteroplacental insufficiency, but when you say uteroplacental insufficiency, it means that there's lack of blood, oxygenated blood going to the baby. Therefore, maternal hypotension leads to that. So this is late deceleration. So you will not choose this. Okay, it's not variable. So what about cord prolapse? There's the word cord. It's a yes. So the correct answer here, guys, 1, 2, 4, 6. So please do not forget oligohydramnios. Okay? So good, good, good. Okay, moving to the next question. You still good, guys? Learning, learning? Okay, that's great. Here it is. A nurse is preparing a client for a scheduled transesophageal echocardiography or TEE. From the word itself, it's possible that you're not familiar because it might not be practiced in the hospitals that you've rotated in your practice, but transesophageal echocardiography is better than your regular echocardiogram because it is, in the flexible tube is inserted in your esophagus, and because the heart, so you have your esophagus, it's right next to the heart, right? So the visualization is clearer here. So the question is, which of the following laboratory results should the nurse review prior to the procedure? Select all that apply. So I want you to think about the procedure. It's TEE, guys, transesophageal echocardiography. So here, I'm gonna use just a picture, especially for those who have yet to see this. So this is your transesophageal echocardiogram. As you can see, there is that transducer, transducer that they introduce into the esophagus. Okay, so just imagine what is required. So to give you just a mnemonic on, which are important to recall, I'm gonna give you the mnemonic safety, but the letters are T-E-E instead of safety, it's T-Y. So safety. The first important thing is safety, of course. So with safety, pause up, the patient should be side lying to prevent your aspiration. And do not forget to remove dentures. Okay, so these are quite important. Next, assessment. What do I assess? You assess for baseline data. Which baseline data are important? Vital signs are important. Important is for you to know your bleeding tendencies. Why? Look at this. You are inserting this tube into the esophagus, guys. Medyo parang papasok dito yung deep throat. More than
Mentor Che, is there an effect, for example, if the patient's taking an anticoagulant, do they have to stop it?
Yes, sir. So those medications that can cause bleeding will be withheld. Okay? Kasi ayaw natin, we don't want our clients to bleed out during or post-procedure. Okay? So that's why part of your assessment post-op will be to check for hemoptysis. Okay? So there you go. Next, you have, aside from your baseline data, of course, you have to check O2 levels. Okay, these are part of your assessment. Okay. Next, because this would require sedation, you should fast. Okay? Make sure there is fasting. 6 to 8 hours is your recommendation for fasting. Because it's an invasive procedure, as a nurse, you have to ensure that consent was signed. You will not be the one to sign to describe the procedure to your client, but it will be the doctor who will perform this. But it's your responsibility to check that the consent was actually signed prior to this. Next is to check for throat pain after. O, diba? As you can see, if you go for deep throat, there could be throat pain. So what do we do with throat pain? Mama Claims, expertise, char. So
Believe
what do we
the
do?
baby that's causing the ectopic pregnancy.
Esophageal pregnancy. So throat pain, guys, we do give your saline gargles after. Okay, if there is, any any pain, or you can give lozenges. Yeah. So for the pain. Then of course one important thing to as as preparation is to make sure that there are emergency equipment bedside just in case. Okay, emergency equipment bedside just in case, there is airway obstruction afterwards because of, let's say, throat edema. So what you do is you have your O2, your suction there. That's important. And lastly, aside from your emergency equipment, make sure that the gag reflex has returned. So that's part of your education. Usually they use here your lidocaine spray or to suppress the gag. So educate your patient that to wait for gag to return before oralizing. Char.
Wow, that's an excellent acrostic. Safety, I love it.
Yes, sir.
Mentor Che, there are modifications of your TEE. Some would usually use a contrast medium, in which case I just have a tip for those who are about to take the test. Whenever
Mm-hmm.
a procedure, like for example, if the doctor opts to use a contrast medium for TEE to enhance the visualization of the blood vessels and the heart, it's very important to assess if the patient's taking metformin, because if metformin combines with the dye, it causes lactic acidosis that's very harmful to the kidneys, and this could potentially lead to acute kidney injury. So that's an important thing to note if your patient is a diabetic and the doctor opts to use contrast medium before for the TEE. Okay, so thank you.
Wow. Thank you so much, Doc, for that update. In addition to that deep dive on TEE. So with that in mind, guys, which of the following lab results should you review prior to your procedure? Please tell me on the chat box the numbers that you will choose here. Is it one, two, three, four, five, six? Which will you answer? Camille has an answer. I love it. What about the others? Come on. Come on. Come on. Doc, everybody says three, four, five, six. And that is the correct answer. Yay! Good job, guys! Because of, why do we check PT, prothrombin time, hemoglobin hematocrit, INR, platelet count? These are all indication of possible bleeding. BUN electrolytes, there's no contrast medium, as was stated if it's the regular TEE. So you don't need to check the BUN. Electrolytes, well, potassium and sodium, this is not affected by your TEE. But the bleeding is your highlight. So there you go. Guys, are you learning? Good job, everybody. So we go to our next one. This is all about MAN2 test, your tuberculin test. Okay, tuberculin skin test. So a nurse is interpreting the results of a MAN2 tuberculin skin test administered to a client who is HIV positive. Okay, there you go. The client has an 18 millimeter area of erythema and 5 millimeter of firm, raised, and thickened part at the injection site after 48 hours. Which of the following best describes the nurse's interpretation of the test? Before I answer, can you tell me your answer here? Is it negative, positive, inconclusive, or negative because the duration should be at least 10 millimeters?
I think, Mentor Che, there's one phrase that's confusing them. There's a phrase there that says 18 millimeter area of erythema, meaning area of redness. Now the question now
Yes.
is, when we're trying to interpret TST, do we really need to include in the measurement the area of erythema or redness, or just the area
Duration.
where you have an induration, or described as a firm, raised, and thickened part at the injection site? Okay, so a lot of them is getting confused now.
So, guys, 5 millimeters of firm raised and thickened part is what you're looking at here. So the induration is what matters. Not the redness around it, but the induration. So now, what will be the correct answer? So we got confused. So the correct answer, guys, is 2. This is a positive result because the induration of more than 5 millimeter is considered positive for clients with HIV, which is actually lesser than regular clients, right? So, do you still recall? So, some of you are confused, must be read at 72 hours. No? So, we have 48 to 72 hours. That's the window. But, at 48 hours, you can read the Manto test already, the results already. Okay? So actually, the problem is if it is more than 72 hours. So that will prove to be a problematic. Okay, so how does it compare? So we've mentioned this is in comparison with HIV positive clients. Why does a 5 millimeter induration a confirmation of or a positive result? So you know the pathophysiology of HIV positive clients, right? You know the major problem. The major problem is that their immune response is depressed. And with a depressed immune response, there's a possibility that it will not react. Although they're positive, they have the bacteria, they might not react with the skin test because they're immunocompromised, meaning their immune system is not reacting well. So that's why a 5 millimeter induration is already considered positive. Okay? So normally, if you're a health worker with moderate risk, so 10 millimeters, right, is considered an induration for healthcare workers. So this one, okay, induration must be at least 10 millimeter. So this is positive for healthcare workers or those with moderate risk, those who are exposed to it. So for example, this is NCLEX based. So if you're an immigrant, so let's say for example you're coming from the Philippines and you're going to the US, so a 10 millimeter induration is considered positive already. But for low risk individuals, 15 millimeters induration is your positive. So this is for low risk. So it requires like a 15 millimeter induration for low risk. So moderate risk, that's 10 millimeters. Healthcare workers are included there. So, but as I've mentioned, for HIV positive, so we want to, they are kind of less reactive because of their immune compromisation. So a 5 millimeter or more is considered already positive. Got it, guys? So I think many of you got 2. Got the 2 as the answer. So we're down to our last one. So this is it. It's amniocentesis. A pregnant client is scheduled for an amniocentesis at 18 weeks gestation. She asked the nurse how the specimen will be collected. Which of the following responses best describes how the specimen is obtained? What will be your answer here? So it's just the procedure, how it will be obtained. Amniocentesis. Is it a catheter inserted through the cervix using ultrasound guidance? That's your chorionic venous sampling. So one is out. Is it a needle inserted into the amniotic sac via the abdominal wall using ultrasound guidance? Yes. So that is your correct answer. What about 3? A swab. Oh, there you go. Swab is to collect fluids. What's that? Swab collecting fluids in the vaginal fornix. So that's not amniotic fluid. That's cervical specimen or vaginal specimen. What about 4? Laparoscopic. Uh, no. So that's, this is not used in standard amniocentesis. So, well, yeah. So this is not your answer as well. Now, what is the purpose of your amniocentesis? Let me just give you a mnemonic for this. I'm gonna give you amnio. Let me find where to write this one. Amnio. So letter A, one major purpose is to check for abnormalities, be it genetic or chromosomal? Purpose of your chromosomal. Letter M. Aside from your abnormalities, we look for maternal and fetal incompatibility. Example of that is your RH, incompatibility. So you can check that using your amniocentesis. Another one, letter N. So I'm gonna go right here because this is where the NTDs. So neural tube defects, screening. So remember your meningocele, anencephaly. Okay, so this is another one of a perfect purpose. Letter I is infection diagnosis. Sorry if my table is moving when I write, so the screen is also moving. And lastly is organ maturity check. So another purpose is to check, especially fetal lung maturity. So that these are the purpose of your amniocentesis. So you have the mnemonic amnio. There you go.
That's a wow, Mentor Che. We've just reached 2,500 viewers on Facebook.
Wow.
A lot of people are viewing. That's a symbol of, that's a reflection of the trust they have in the system. And your advice, Mentor Che.
Thank you, Doc. There you go, guys. So I hope that you've learned from that part of your diagnostics.
So can we also have some few words from Mentor McLean, your advice to those who are taking the test anytime soon, within the week or within the month or so?
Ay, ako na ba? Ay, sino na yung tong... Okay,
Yes, your
so...
advice.
Okay, sino ba tong naka... Okay, so for those who will be taking their exam for this coming month, for a couple of months from now, so always believe that you need to equip yourself with a system that works. And I always make sure to advise them that they have to be ready and they have to be like what you said earlier on, sir, they have to stay updated because there are times that the NCLEX will definitely play your mind as well. So what you know from 3 years back, from what you know this day on. Okay, that's my advice.
So what matters the most is be updated and
Yes.
get yourself into a system that works. I love that. So please feel free. I think the 85ers would also have their next free NGN soon. That's live. Now, the good thing about the 85ers is that you are given the opportunity to use our simulator, right?
Yes, definitely,
And
sir.
that's at the
Yes.
second floor of the Ray A. Gapo System building in UN Avenue, the only NGN simulator in the world that works. And a lot of people are saying those tests in there those tests are really life-changing. Okay, so thank you for all of you who opted to spend their weekends with us. On behalf of Mentor Che and Mentor McLean, this is your mentor, your fact check buddy, Ray Gapos, sa ngalan ng nagsasabi ng totoo. Serbisyong totoo,
Totoo.
walang kinikilingan. Eh, ganon.
24
Walang
oras.
pinoprotekta. Nandito
Bandila.
lang tayo sa sama-sama nating pagiging witness.
Saksi.
Ganon. Ayan
Sexy.
po, nababaliw na naman kami. Good luck, everyone. God bless you all. And thank you very much for joining us. See you in our next updates class only here at the Ray Gapos Review System with the 85ers lead mentor and our Vice President for Research and Program Development. Our wish is for you to shut down at 85.
85.
Keep believing that you can, and we know you will. Take care. Have a pleasant evening. Happy weekend. And to all of you who are joining us from any part of the world, thank you so much. See you and take care.
Bye, everyone.
Bye, everyone.